This is really a special evening tonight. We normally have one expert speaking with us, but tonight we have four experts who are going to be presenting this information, which is so critically important. And let me quickly and briefly introduce them because there are four. We'll keep it a little brief. But Dr. Lily Dastmalchi who was with us last week, and she's back again this week. She is a board-certified cardiologist in cardiovascular disease and echocardiography. She joined Inova in 2024, has been practicing since 2018. She has a special interest also in weight management, and she'll be talking about that a little bit. She aims to provide a holistic approach to cardiovascular care. Her clinical interests are in preventive cardiology, which includes nutrition education, cholesterol management, hypertension, interpreting and managing calcium scores, and cardiometabolic health. She's part of the Women's Cardiovascular Health section of the cardiology group and leads the menopause program at Inova, which includes a multidisciplinary team composed of specialists to provide individual care during this transitional period in a woman's life. Dr. Shawn Davis-Wilensky is with us as well. She is a specialty care physician board certified in obstetrics and gynecology. She joined Inova in 2023 and has been practicing since 2003. Prior to joining Inova, Dr. Davis-Wilensky was a physician at Foxhall OBGYN Associates in Washington, D.C. As part of the team from Inova Seville Screening and Prevention Center, she helps breast cancer patients navigate menopause. Dr. Erin Perucci is a specialty care physician board certified in obstetrics and gynecology. She joined Inova Health System in 2020 and has been practicing since 2008. Prior to joining Inova, Dr. Perucci worked as an OBGYN at a private practice in Arlington, Virginia. And finally, we have Dr. Garima Sharma, who is director of our cardio obstetrics and director of cardiovascular women's health at Inova Health Systems and Inova Shar Heart and Vascular and Inova Women's Collaborative Program. She's board certified in cardiovascular disease and sees women with cardiac disease during pregnancy, treats hypertension, spontaneous coronary artery dissections and disease and lipid abnormalities, works with patients with risk factors for severe cardiovascular disease who are in menopausal transition. Dr. Sharma is a national leader in women's health, and I'd say international leader in women's health and preventive cardiology. She has published more than 100 peer-reviewed articles in top-tier academic journals and has led several national and international educational conferences in women's cardiovascular health. This is an incredible panel, folks. Now, I'm going to turn the program over to Dr. Dastmalchi, who's going to give a brief presentation, and then we're going to have all of our panelists talking to each other and also responding to questions that you put in the Q&A box, not in the chat. So I'm going to turn off my camera now, and I'm going to let Dr. Dastmalchi bring up her slides and see what we got. Thank you.
Thank you, Dr. Levy. I appreciate the kind introduction, and I hope to whet everyone's appetite for menopause. So let's get started. As you know, the topic for today is protecting heart health before, during, and after menopause. I have no significant disclosures. And we just very brief introduction here. I really want us to focus on talking to the experts today, just mainly a few topics of interest with the presentation, and we'll get started. So really, why do we care about cardiovascular disease in women's health? Well, we know it's the #1 cause of death in women worldwide. It is a major cause of morbidity and mortality in women, in adult women, I should say. And unfortunately, it's incredibly under-recognized in women in the US. So this study that came out in 2020 showed a decline in the awareness of cardiovascular disease risk in women from 65% to now 44% who are aware that cardiovascular disease poses a threat to a woman's life. But what about menopause? Well, we've had decades of research that have shown us that women develop coronary artery disease later than men. What we've found is that menopause, specifically a time period called the menopause transition that I will help define for you in a moment, can contribute to the development of risk factors and cardiovascular disease itself. There are multiple alterations in the sex hormones that can lead to changes in fat deposition, cholesterol, and vascular health. Menopause itself doesn't necessarily cause cardiovascular disease, but it elucidates these risk factors and brings them to surface that can make it very important to manage those risk factors during this life stage and help alleviate the risk of cardiovascular disease and mortality later on in life. So like I said, menopause is not one moment in time. It's a full transition of the life stage. I'm sure many women who are going through this can tell me that as well. We have premenopause, which is where you start to notice some hormonal shifts, but you don't really have any symptoms just yet. There's perimenopause, also known as the menopausal transition, and that typically occurs in 40 years of age. And it lasts between 2 to 10 years. Again, incredibly variable and very long. Women start to experience changes in their weight, their metabolic parameters such as lipids or waist circumference and blood pressure can change. They start to have more mood swings and emotional irritability and start to have sleep changes as well. And then ultimately we have menopause that is defined by 12 months of no menstrual cycle, and the average age in the US is 51 years. So here's just another way to show you that we care about menopause as cardiologists, and of course in women's health. The American Heart Association had this nice timeline of perimenopause, menopause, and postmenopause. And what perimenopause, which is the menopausal transition as well, is again, they highlight the key time to alleviate cardiovascular risk and address those risk factors. I just want to show you this image here that menopause is not just about bikini medicine, right? Women are more complex than that. So it affects the entire body. It is a systemic change into the body where you not only have hot flashes that are most commonly associated, but the mood changes, the hair and skin changes, digestion, intimacy, bone health, weight changes. It goes on, and we'll get into more detail about this evening. Additionally, like I mentioned about weight gain, that is something that I'll talk to you more about tonight, but that can impact your cardiovascular health. So we know all these things that are happening during this transitional period can further increase your risk of heart disease later on. Sleep is also incredibly important. I mentioned in my lecture last week about life's essential 8 and how to have good sleep. Well, sleep disturbances do occur during this life stage. And there's also mental health disturbances as well that we know are risk factors or risk enhancers for cardiovascular disease. So what if you do have hot flashes? And that is at this time, what is the indication for hormone therapy? Well, we'll get into that tonight, but truly hormone therapy is only indicated right now for the treatment of vasomotor symptoms. And can you use that safely? Well, we will talk about that more tonight, of course, but we have to assess your cardiovascular risk before starting systemic hormone therapy, whether through a patch or for an oral pill. The vaginal topical treatments for genitourinary symptoms, those are not systemic and can typically be used, but we'll get into that again tonight. So thankfully at Inova, we have a wonderful team of physicians that work together to create our menopause care team. We have a spectrum of cardiology, endocrine, gynecology, urology, neurology, psychology, a dietitian who actually focuses on menopause nutrition, and obesity management. And some of these physicians are NAM certified, which means that you have this proper training in menopause, and many of them are currently studying to get their training done as well. And we treat a various amount of symptoms that we talked about, and we'll get into that as well. And these are some risk factors to think about of whether hormone therapy is safe for you and whether it's even indicated, and that's what our team can help you answer. And most importantly, I want you to be an advocate for yourself. The American College of Cardiology had this wonderful infographic where it's to be your own hero. So truly advocate for yourself, tell your physicians how you're feeling, and they can get you to the right person, especially within the Inova system. We can definitely help each other and help you as the patient. And then of course, focus on life's essential 8, trying to prevent the onset of cardiovascular disease. And with that being said, we'll get the panel started. And I thank you guys so much for having me be here tonight.
Wow, that was a lot real quick. Lily, can I ask you to put your slides back up?
Sure.
We have a fair amount of time. I'd like you to go that one. I wanted you kind of breeze through this slide, and there are already some questions, coming in about, who should be screened, who needs to worry about things. There's a long list of stuff here, and I'm going to follow with a question to Dr. Sharma, but do you want to just go through the slide? It says, who should be referred for multidisciplinary assessment for cardiovascular disease if you're going to consider hormone replacement therapy? And we'll have a lot of questions about hormone replacement therapy. So do you want to just spend a couple of minutes on the slide and even read through all of those bullet items?
Yeah, of course. So this slide is to show you that there are multiple conditions, and I'm sure they're not all on here, but majority of them are on here, that we need to have a more thorough evaluation to see whether hormone therapy, systemic hormone therapy, I should say, is safe for you. So there are some clear contraindications, I would say, where contraindications saying that we would not recommend hormone therapy. That's typically with hormone responsive breast cancer, and I know our experts tonight can talk more about that. Typically, people who have a history of stroke, a history of a heart attack, or have really high risk factors for heart attack, or what we call subclinical atherosclerosis, meaning you have been found to have coronary artery disease from imaging typically. People with a history of lupus, history of spontaneous coronary artery dissection, also known as SCAD. So those are classically the people we would say we would not recommend hormone therapy for you. There are some people where we could say, okay, we can look at the risk versus benefit of hormone therapy. And this would be the people who are obese, have high cholesterol, have kidney disease, have a history of smoking but no longer smoke, may have autoimmune disease that's not necessarily lupus or a procoagulable state, but something on the lines of rheumatoid arthritis or so. And those people we can say, all right, well, we definitely don't want to do oral hormone therapy because oral hormone therapy has more of a effect on our cardiometabolic parameters, such as higher triglycerides and lipids, but we can consider transdermal as long as we control your risk factors first and can safely initiate that. And again, that is a multidisciplinary type of conversation. And then we have people who we can say, okay, it is safe to start hormone therapy. And those are people who've had the onset of menopause before the age of 60 or have had menopause less than 10 years. People who are a healthy weight and don't have any history of hypertension or diabetes or obesity, and people who have not been smoking. And so those are people we can say, okay, well, you're in the safe window of starting hormone therapy that we've seen in that has been defined from prior trials, and you have a healthy weight and lifestyle and cardiometabolic status, then we can say, okay, we could start hormone therapy safely in this individual.
Okay, yeah, we're gonna get back to more of that. So now we can take the slides down. It's just I like that slide and it just went so fast. But let me start out by maybe staying on the cardiology side of things, and I'm going to ask a question to Dr. Sharma, who, as you heard in the introduction, is our director of our women's heart health program. In a nutshell, what do you want women to know about, entering menopause and cardiovascular health and who should be screened? And a couple of people said, well, who should be screened? What tests should I do if, maybe I have a family history and I'm entering menopause and I think I'm okay, but, you know, I don't want to be stupid.
Yeah, absolutely. Thank you, Dr. Levy. Fantastic talk, Dr. Dastmalchi. Congratulations. It's really always great to hear you and focus on an important portion of a woman's life. So one of the things that I want all of the listeners to be very aware, menopause is a significant portion in a woman's life. It starts with perimenopause, which is about 8 to 10 years before menopause, and then the menopause transition, which is, after you've achieved menopause, about 10 years. So this is a good 20 years plus of a woman's life. And what happens during this time frame is that obviously the protective benefits of the female sex hormones, which is estrogen, and the active form of it, which is estradiol, rapidly decreases over time. And there are subtle changes in your blood pressure, in your body mass, in your waist circumference, in your metabolic rate, your ability to burn, calories, your gut microbiome, your ability to really extract the right nutrients, your cholesterol, and your sleep patterns that happen during this time frame. And while in conventional media, menopause is vasomotor symptoms, many people actually don't have any vasomotor symptoms, may have vasomotor symptoms that are actually quite mild and tolerable. But what they may have is significant sleep disturbance and behavioral changes.
You may just want to help say what vasomotor means when you say
Yeah,
that.
hot flashes. The hot flashes, vaginal dryness, lack of sex drive, sweating in a meeting, drenching in sweat wherever you're going, all, that kind of stuff. And while that is a problem because it's embarrassing and it's also extremely difficult for the person to actually bear through, the other subtle effects that I just mentioned are actually far more common. And so having a conversation with your primary care doctor or your cardiologist or your OBGYN or anybody that is focused on menopause care or has a focus on addressing these changes in cardiovascular health is extremely important, and it should start before menopause. It shouldn't start after menopause. And one of the things that we do to assess patients' risk, as Dr. Levy asked, one is really looking at cardiovascular health. So cardiovascular health is 8 risk factors and health behaviors, right? Blood pressure, blood cholesterol, your diabetes level, your BMI, your sleep, your body weight, whether or not you're smoking, your exercise capacity, and what you're eating. So we create a cardiovascular health profile for everybody. And I think everyone ought to know what their cardiovascular health is. Are they in good health? Or are they in moderately good health? Or are they poor health? And, if you don't know, ask your doctor to tell you what that is. And these are numbers that you should know. Based on that cardiovascular health, if somebody already has abnormal cardiovascular health or suboptimal cardiovascular health, we will recommend additional testing. One of the easiest tests to do is what Dr. Dastmalchi mentioned earlier about is calcium score, which is evidence of hardening of your heart arteries on a CT scan. It's a test on a CT scan. It tells you what you don't know. It tells you what's hiding in your heart arteries before symptoms start. And it is a test that you can have your doctor order. And if you have evidence of calcium, you have heart disease. And then you fall into a different category of patients, which requires a more nuanced, patient-based, patient-centric approach of whether or not hormone replacement therapy is right for you. But that is an essential tool in the toolkit of cardiologists that we often offer to patients who want to understand their individual risks.
Awesome. That's a great answer. Let's move on to our colleagues here. Who should I do? How about Dr. Davis-Wilensky? Shawn, how does someone know if they need hormone replacement therapy? There's a lot written in the lay literature, and I certainly don't pretend to be an expert on this. And, it's like the pendulum swings left and right, and we're never really sure, is it good for me? Will it reduce my risk of heart disease? Will it increase my risk of cancer? How do you make that decision? And I always see it said, well, you should have this discussion with your doctor. But when you sit down with a patient who wants to talk about hormone replacement therapy, what are you talking about, and how are you presenting the risks and the benefits?
So, when I'm first talking to someone and I'm thinking about who should, do you need it? And so it's really for helping you with your symptoms. So if you don't have symptoms and you're not prematurely in menopause, you don't have to have it. But for many women who are having symptoms, and most commonly like the vasomotor symptoms, the sleep disturbance, vaginal dryness, those things, then hormone replacement is a very good option. For myself, a lot of the women that I'm seeing are women who've done something like risk reduction surgery. They've had their ovaries taken out because they have high risk. So they're going into menopause at 35, so many, many years before the average age of 52. So for those women, we may think of it more as a way to kind of lower their risk for cardiovascular disease, for bone loss. And so those women are a totally different group because we are doing it in a more preventive manner, and we're doing it at higher levels to improve their health. But for everyone else, we're really doing it to treat symptoms. So if you have symptoms, that's when you want to have the discussion.
Great. I'm going to come back to hormone replacement therapy because there are a lot of questions, but let me throw a question over to Dr. Dastmalchi. Lily, you spoke to us last week about sort of the 8 risk factors, and we talked a lot about diet and weight loss.
Mm-hmm.
How do the new weight loss drugs kind of play into this equation? You talked about how it's a natural part of menopause to gain weight, and a lot of people don't want to. and they're going to come to you saying, you know, hey, I heard about all these really cool new drugs. Is this something I can do for like a couple of months, lose a few pounds and move on? Or, you know, what do you want to give us a real quick primer
Yeah,
up?
quick. Okay, I'll do my best.
Yeah. I'll cut you
I'll do
off.
my very best. Quick is not in my nature, but I will give a brief background about menopause and weight gain, and then I'll answer your question, I promise. So during the menopause transition is when we see the most amount of changes in regards to the ratio of your waist circumference and your hip circumference, your hip ratio. So typically you want a larger ratio between your waist and your hips. Women typically end up having a smaller one during the menopause transition. You build a lot of fat around the midsection of your body, and we can get into the complications of that later on. But what we also see is muscle loss. A lot of women lose muscle mass and they gain adipose tissue. And that is why I usually educate women that it's imperative that they do weight-bearing exercises. That's safe, but they do weight-bearing, and they also increase the amount of protein that they're consuming so they can kind of keep up with the muscle loss that is occurring. Now, when it comes into the GLPs, it becomes a little bit more of a individualized conversation. You know, I had a patient today tell me that one doctor told her she could jumpstart her dietary goals with a GLP and then come off of it. If you were present last week, you would know that is not the case. So GLP-1s, as effective as they are long-term medications. Just as any other chronic medications you're taking, it is lifelong. We know that when you stop those medications, you gain at least 2/3 of that weight back rapidly within at least 1 year, but maybe even faster. And when women are going through menopause, and we know that women who are obese do at times have worse vasomotor symptoms. They also have more cardiovascular complications, such as increase in cholesterol panels, worsening in hypertension, insulin resistance. So losing weight is incredibly important, but they're also dealing with the slower basal metabolic rate, the increase in adipose tissue, and the loss of muscle mass. So GLP-1s can be helpful with the patient understanding that it is a lifelong medication, but they will need a lot of protein intake and a lot of weight-bearing exercise because they're already almost being fought against them, because during menopause they're losing the lean muscle mass that we want to keep that is more cardiometabolically favorable. I hope that answers your question.
It does, and I think the real what I learned a lot from your talk last week. But one of the things I learned is that the GLP-1s, it's not short-term therapy. It's lifelong therapy, and it's for specific indications. And I think the lay press kind of makes this out to be kind of like a party drug or something, you know, that you can just take it and short term. Let me ask Dr. Perucci a question. You know, are there certain characteristics that a woman may present during menopause that would make you think that she's at greater cardiovascular risk or would benefit more from hormone replacement therapy, not just for symptomatic relief? Are there things that when you're seeing women during their perimenopausal period that you bring this up in the conversation because of things you're seeing?
Definitely studies have shown that the intensity sometimes of patients' symptoms can, increase their risk of cardiovascular disease. So sometimes the patients have extremely intense symptoms, and there really is a huge spectrum of how women experience menopause. And then, like Dr. Davis-Wilensky said, I'm always bringing it up to patients who are on the earlier end of the spectrum of having their menopausal transition, because surprisingly enough, that's missed by a lot of physicians, where patients will, now, someone who's having risk reduction surgery, ideally is hooked into already a network of doctors that's thinking about that. But a lot of times they're not. And a lot of times I just get a patient who had her menopause at, 39, and nobody ever said anything about it. And, she never really told her doctor. And, she's a couple years older than that. And we talk about potentially treating because she's at higher risk. So.
Yeah. Thank you. Garima, This always comes up because people get confused, and I've been typing answers to. You don't know that I can sometimes type answers to the simple questions, and but there are a lot of them about coronary. You mentioned calcium, and I think you mentioned coronary calcium scores. People don't know what a coronary calcium score is and how it's done, and in addition, I think a lot of women get confused about calcium because a lot of times for osteoporosis, they're told to take calcium. But we're telling them if they have a coronary calcium score, that's a bad thing. So can you just explain a little bit the difference? We're talking about two different things
Yeah.
here, and exactly what a coronary calcium score is.
Yeah, absolutely. So it's a great question, actually, because it happens all the time. So coronary calcium is not dietary calcium. It's not calcium that you're eating because someone told you got osteoporosis and that that calcium is somehow magically finding its way inside your heart arteries. That's not the case. That's a very big myth. Coronary calcium is hardening and changing of the heart arteries over time. It doesn't happen in a day or in a year or even a couple years. It takes years for calcium to get inside the heart arteries. What happens is that for whatever reason, whether it's diabetes related, or it is diet related, or it's cholesterol related, or it's blood pressure related, the lining of the heart artery is slowly nicked or tears over time, small tears. And if your body's cholesterol finds its way inside that artery, it gets trapped in there. And over time, the body recognizes that cholesterol really shouldn't be in that heart artery. It's got no business being there. And so it tries to sort of take care of its own self by sending, inflammation and markers that sort of help take care and confine that cholesterol particle and, prevent it from getting worse. But the way to prevent it from enlarging and getting worse really quickly is to actually changing it into calcium. So the calcium is a end product of what's happening with inflammation inside your heart arteries over a period of time. You can assess that. Your cardiologist or your internist can assess your body's coronary calcium by doing a test, which is a CT scan of the heart, which is primarily a scan done in a few seconds, runs over your heart really quickly without requiring you to get an IV line or anything else. You go in with a prescription to your, radiology or center that can do this. And they quickly run this and they will spit out a score. A score is defined by the evidence of that calcium lighting up on the CT scan. It looks like bone. So they're going to look at your bone and say, oh, there's evidence of calcium because it looks exactly like that. And then they automate it and they create a score for you, which is how dense that calcium appears to be and how bad that calcium appears to be and where it appears to be, and gives you a score. And they compare that score to other women or men your age that have had scores like this in the entire country and give you a percentile risk or an accident percentile risk or a score. Now, if you have zero calcium, that tells us that you have no evidence of heart arteries and you're good. There is a power in having zero calcium. We call it power of zero, which means prognostically, unless you really change your lifestyle dramatically, test is actually pretty good for about 5 to 8 years, and even 10 years in some cases. Now, if you do not have a zero calcium, then they can tell you how much there is. So it can be 0 to 100, it can be 100 or greater, or 300, 0, 100 to 300, and 300 or greater. People who have a score that is over 100 definitely have increased risk of heart disease, because we have a lot of data that tells us that if you have heart artery hardening and it's 100 plus, that's a problem. If you have a greater than 300, it's equivalent to having had a heart attack, which means even if you didn't have a heart attack, your risk of dying or having a repeat problem in the next 5 years is similar to somebody who's already had a heart attack. So it's a really important score because it is your score. It's like, people that, you basically have a scoring system that gives you a tag. They tagged you, and they told you this is your problem. And so that is coronary calcium. dietary calcium has nothing to do with coronary calcium. Supplements that you're taking for osteoporosis, that your doctor told you, take vitamin D, take calcium, osteoporosis, is not going to give you coronary calcium. And no matter how much you eat of that dietary calcium, you're going to pee it out, or you're going to, it's going to end up outside your body if you don't need it. And so dietary calcium, whether it's a food or a supplement, will not make its way inside the heart arteries.
Period. Thank you. Exactly. Dr. Perucci, okay, I'm gonna hit you guys with some quick hormone questions. Let's just try to kind of power through them. So, yes or no, hormone replacement therapy will reduce the risk of cardiovascular disease? Yes or no?
Nuanced. So,
Exactly.
if we are treating someone who has had premature menopause, then yes, potentially. If we are treating someone in the right time, so in the menopausal transition within 10 years of the last menstrual period, or by age 60, ideally, then yes, we can put, some studies have shown we can have an impact there. Some studies have really shown no impact. So, do we have a definitive answer? No.
Is there
But
an age cutoff? Is there an age cutoff?
the cardiologists say yes. I don't necessarily say there's an age cutoff. I think, again, we have to look at the person's whole history. Someone was a very late menopause. They didn't have their last menstrual period till they're 57, and she's 61, and she's wanting, then again, we're going to have the conversation. We're going to look at the whole patient and see if health-wise she's a candidate. So I don't say no.
You guys, your talk is so good. I have an 80-year-old here who wants to know, should she be starting hormone replacement therapy? Is there a point at which, it's almost like saying, should I start statins when I'm 85? I mean, we get that question in cardiology, right?
I say to patients, there is we know a benefit window. And at 80, you have pretty much missed the benefit window. Now, if you have terrible vasomotor symptoms that are still plaguing you, then we can talk about, is that worth you taking on extra risk to treat those? We now have a lot of very good non-hormonal treatments as well. Something called Veoza has really revolutionized how we treat older people. So has been very exciting. But, we're still going to have that conversation, and we're going to weigh risks and benefits.
Excellent. Thank you.
Too much risk.
Thank you for that great answer. Dr. Davis-Wilensky, vaginal estrogen cream, does that lead to a risk of any kind of cancer? Folks wanted to know, can that lead to cervical cancer? Is there a risk, or is that just purely topical?
Oh, vaginal estrogen cream or pill or the ring does not increase the risk for endometrial cancer in the lowest doses. There is one that is a systemic dose, but the majority of them are the low dose ones. And we even use those in women with a history of breast cancer because there's very little systemic absorption. And there are studies to prove that. And for the 80-year-old woman, this could be an option. She has a new partner. She's getting married at 80. This is something that would make more like sense for her.
Exactly. Thank you. Lily talked a little bit about how blood pressure goes up with age. I think that was part of your talk. And does hormone replacement therapy affect blood pressure? I'll make that a toss-up question for anyone. Jump right in. Garima, you were shaking your head.
Yeah, so it depends. I think that it would depend on, first of all, what kind of blood pressure you're starting with. Recognizing that hormone replacement therapy is basically you're getting hormones over small doses of hormones over a period of time. There have been studies, and I'll let the hormone replacement therapies also specialists also chime in here. There have been studies that have looked at the oral hormone replacement therapy versus transdermal hormone replacement therapy and their association with worsening systolic blood pressure. And what I found, systolic blood pressure is like the top number of your blood pressure, the bigger the top number versus the bottom number. And what they found is that the transdermal patch does not increase your blood pressure. The oral systemic hormone replacement therapy, the estrogen, has been associated with slight increase. But you have to sort of take that into context with other risk factors that the person could have that also complicate that question. You know, what is their diabetes association? What is their exercise capacity? What is their body mass index? And tease that out individually. You know, I'll let others also chime in.
Any other thoughts on the topic? Or I'm going to move on. Erin, can someone who's had breast cancer, can they take hormone replacement therapy if they've been treated?
So to treat genitourinary syndrome of menopause in the vagina with topical treatments, absolutely. Now, you know, again, I'm a big fan of the nuanced conversation for people. And I have had patients who have had breast cancer, all different types, estrogen sensitive, estrogen non-sensitive. And we have that conversation about the risk of potential recurrence. Most studies have shown that there's not an increased risk of dying from breast cancer from hormone replacement therapy, but potential recurrence and distant recurrence. You know, again, we have more non-hormonal options to go over with them now, which is very helpful. But I have had patients who have had such bad vasomotor symptoms from prophylactic oophorectomy, so removing their ovaries, or endocrine therapy that, you know, which blocks estrogen and all their receptors, that they feel they are willing to accept the increased risk to have better quality of life. This is not the majority of patients, you know, but I, again, think everyone deserves to have the conversation with their physician. You know, I think Dr. Davis-Wilensky would probably agree with that.
And this is the message I'm taking so far away from this. There are a lot of questions here that I'm not passing along that have to do with me, like I'm this and should I do that, and right. And I think the real answer is every one of those questions. The answer is you need to sit down and talk with your physician. They need to look at your risk factors, your potential benefit, and then you need to make a decision together. There's no absolute right or wrong. There's no yes or no. And it's really a sort of joint decision making in making these decisions with patients. Would you agree?
Yeah, and I would say if someone gets an answer from their physician, like just a blanket statement, like, no, this is not safe and you can't use this, then unfortunately your physician is not really up on the latest data on how the conversation should be had. And that's when it's best to seek out a menopause certified practitioner. There's lots of different resources for that, so that someone can really have the educated conversation with you. So if you're getting that blanket statement, you can't use anything just because, that's not the best answer.
I think that's great advice. Shawn, does someone need to take a progesterone in a combination with estrogen? And I guess I'm not sure if they're talking about hormone replacement therapy or birth control, but because of the risk potentially that can lead to.
Yes. So definitely for those women who have a uterus, they need to have progesterone if they're having systemic estrogen, and that's to prevent endometrial cancer or uterine cancer. So without a doubt, and there's a lot of forms now. They could have an IUD, they could have a pill, they could have a patch. So there are many options, but they definitely do need it. And that's scary, I think, for some women, because with the WHI, the estrogen plus progesterone is the one for invasive breast cancer and the majority of the risk. And so people want to say, well, why can't I just take an estrogen? Then I won't get the breast cancer, but then you'll get endometrial cancer or uterine cancer. So it's best to take a progesterone if you want to have an estrogen and you have a uterus.
Okay. Again, it's amazing how we've been talking about this for so many years, and it's not black and white. Lily, how about lipids, statins, and menopause? As women get older, enter menopause, you mentioned, I think, that their lipid profile can change a little bit. What criteria do we use for who needs to be treated for high cholesterol? Does that change at all for women who are perimenopausal, or are we using the same guidelines we use for everyone in the population?
Unfortunately, that's also not a black and white answer. So what we know is that we have the pooled cohort equation, which is our classic equation we use to make sure whether someone's indicated for statin therapy. And we have a new risk calculator as well. Now, one of the flaws that we see with the calculator is that it didn't take into account certain conditions that affect women, such as menopause. What we've seen in research studies using large population data is that some parameters of our lipid profiles do change negatively. So we have increases in the LDL-C, which is some people call the lousy cholesterol, but really it's the low density cholesterol that typically leads to coronary artery disease. And then we have sometimes reduction in the HDL cholesterol which is typically our happy cholesterol, some people call it. And that's the one that is responsible for clearing out the bad stuff and getting it out. Unfortunately, I've been seeing some women with higher HDL, but research has actually taught us that those particles are dysfunctional. So during menopause, we have alterations to the integrity of the HDL particle, where it's no longer able to clear out all the bad stuff from our body and take it out. So I've seen a lot of women who come in who said, oh, well, my risk was seen as low. I have high LDL and it was untreated because, their equations showed that they were low risk. Well, knowing what we know now about women's health and their risk of heart disease during this transitional phase, I actually say, let's do a LPA molecule, which is it's inherited from your parents, and it gives us insight as to someone's inherent risk for heart disease. It's a risk enhancer. And then I also do a calcium score that we talked about in great detail with Dr. Sharma. So I do those two things to get a really nice composite holistic picture of what someone's lipid status is. And then we make a discussion with the patient and make the next best step. So unfortunately, it's not a blanket statement of what what to do based off a calculator or score, but I really think it's really important for these women to do a thorough investigation and do the best thing for them to lower their cardiovascular risk.
Great. You mentioned a sort of a dirty word, LP little a. Not a dirty word, it's a risk factor, but how do we treat elevated LP little a's?
Yeah, so great question. I mean, there are ways to lower it, but we're waiting for outcomes data, right? So we're trying to see if we lower the LPA, what happens. So right now we have the LPA, if it's high, we become more aggressive with managing the cholesterol. If it's normal, we decide, okay, let's see whether we continue with statin therapy or we be more aggressive with lifestyle management. But I will say in menopause, lifestyle sometimes doesn't exactly change the cholesterol. It really is an increase that is from the ovarian aging that is occurring.
Yeah, a couple of things. First of all, a lot of people ask me this question, and there are no medications right now specifically designed to lower LP little a. There are clinical trials ongoing with new medications, and I think we will have some. But the other thing, in terms of risk, and I don't want to wander too far from the subject, but people say, well, if I can get my cholesterol down with red rice yeast or something, or just with diet, is that going to reduce my risk of heart disease as much as reducing my LDL down to 70 with a statin? Is it just the lowering, or is it how you lower it that really reduces risk? And go ahead.
That's a great question. So red yeast extract, I've heard about it for years. It is equivalent to essentially a very low dose of pravastatin, which is the lowest intensity statin that we may have. There was a really good trial that came out a few years ago, I believe at American Heart Association, that looked at supplements that we use to lower cardiovascular disease risk and outcomes. It didn't show much benefit. I think it's more so how we change it. So I don't think one supplement that is unfortunately not FDA approved, you don't even know what you're really getting with those supplements, if it's really going to lower your cholesterol. I think using a medication, or I say an FDA approved supplement sometimes to patients that we've been studying for years, that can help lower your cholesterol. And also lifestyle is so incredibly important, and we'll work together to find the best lifestyle for them and lower their cholesterol safely and effectively.
That's great. Erin, there's a great question here because I think people are wondering. It said, I'm going to read it verbatim. It says, if we want to make an appointment to have these conversations with our physicians, is there a particular visit type we should ask for so that the physician has the time and knows that this is really why we're coming in? I mean, I think it's a great question, right?
Thank you to
So,
whoever asked that question because
all right, kudos to our anonymous attendee. Okay.
100%. And what I will often do, because what are women seeing us for a lot is their well woman exam, and they bring up a lot of these extra questions. And I will say to the patient, you know what? This is a really important conversation that actually takes its own visit because I have so much to go over with you, so much to get into with your health history and all your issues and all the options. And I actually have my office for most of these, unless it's a very well established patient, book 30 minutes. And it takes that long. And often the patient is in tears and no one has listened to her. And and so I even stop patients right there. But that would be something if you're calling, say, I want to book a time to speak with my patient or my physician about hormone therapy, my menopause transition, my risk factors, so that it's separate from a well visit or something. It is really its own conversation to be had.
And you really need to be your own advocate a lot of times. There's a question that we're trying to ask patients when they come in before they see the physician, which is like, what's most important to you today? What is it that you really want to talk about? Not what the doctor wants to talk about, but like, why are you here? And we sometimes, we all sometimes get lost diving into some of the medical details of caring for our patients that we have to come back to that question. Shawn, I was going to ask you something. Oh yeah, it's one of the things that we had talked about before the meeting, and part of it is how long should women be on hormone replacement therapy if they're on it, and how do you decide when to stop? I guess that's really the question. A woman's gone on to hormone replacement therapy mostly for symptomatic relief. When do you stop?
So for those for symptomatic relief, it's hard because they're on and they don't have symptoms. And so
Right.
I actually go probably, a year or two. And then in each year, we kind of talk about, are you getting any breakthrough symptoms? How are you feeling? And then we start to kind of like, I'd start, mid-range and I will drop them down a little bit and see how they do. And if they do fine, then we stop. And it's a trial. If they're not good with that, then we restart their medication. But we do actually pay attention, like intentionally think about this each year, whether you want to continue going and how other things in your life are going also.
So it is an ongoing conversation that you're having with patients. Okay.
A lot of women have been told that there's cutoff times. You
Or
reach
not.
this age, you absolutely have to stop. And right, it just really doesn't exist. And it's that ongoing health assessment every year. And there's going to be a really small subset of people that have severe symptoms forever. Those people, we have that risk-based talk. And then there's going to be people who, yeah, they're on for 5 years, they come off, they feel fine.
Lily, more weight loss questions. For a woman who is menopausal, postmenopausal, who wants to lose weight, are there any, specific recommendations you make that may be different from the 30-year-old woman who comes in and wants to lose some weight? And it doesn't fit one of those categories of risk that would qualify for GLP-1s.
Yeah, so that's a great question. I think, again, incredibly individualized. We know that women who are postmenopausal have a lower basal metabolic rate than they did when they were 30. Everything kind of slows down a little bit. You gain weight faster, you gain fat faster, you gain muscle a lot slower. So I typically recommend, I'm a big fan of a plant-forward diet, meaning eating a lot more, adding more vegetables, adding more plant-based sources, and minimize the amount of red meat and processed meats. You can eat lean proteins, of course. I do typically recommend increasing the amount of weight training to help build that muscle mass, because the science of weight loss is two things. One is calories in or less than calories out. That is the basics. And then two, in order to lose weight, the first thing that goes when you do hypocaloric diet is muscle. So we are very prone to losing muscle. And in order to negate that, we need to consume more protein and do muscle building exercises. So for women who's postmenopausal, I highly encourage doing more cardio, whether that's fast walking and, you know, wiggling their hips and getting short of breath where they can't have a conversation. That's a healthy way to do it. Doing some weight training that is supervised and safe, because it's also good for their bone health. That's also incredibly important. And then also, again, eating good source lean animal proteins and vegetable-based proteins are exceptionally important as well to get fiber intake and the micronutrients you get.
Yeah, and I think one of your slides that kind of flew by was 150 minutes, 150 minutes a week, and that really goes for everyone, not
Yes.
just perimenopausal women. 150 minutes a week
Yes.
of some form of activity that sounds like exercise. Hey, a question here on vitamin D. Lily, I'm going to stick with you since you're our dietary genius. You know, a lot of people have been told to take extra vitamin D. Is there a risk of taking too much? And I guess, and I don't know if this is true, that vitamin D helps with hair loss around menopause. You're talking to the wrong person right now, but does vitamin, I should have taken more vitamin D. No, does vitamin D help with hair loss, and is there a risk of taking too much vitamin D?
So again, there's no easy answer to that. Vitamin D is exceptionally important with immune function. It can be helpful for hair loss from what I've read. Again, these are things that need to be more well researched. For menopause specifically, there was one study that looked at the micronutrient intake, and they found some benefit in vitamin D in regards to just having a healthier micronutrient profile. They didn't see any cardiovascular outcomes, and that's kind of what I'm looking at more so. But they did see better, I don't want to say weight loss, but healthier ratios. However, it was one study that was done in Europe, and hasn't been a follow-up study since. So I don't really want to bank on something that was done very small and hasn't shown major impact. I think if you have a vitamin D deficiency that is shown in labs or insufficiency, then yes, you should be treated. Again, vitamin D is very important for overall systemic function for a lot of the things, you know, immune function, things of that nature. But specifically for menopausal treatment, I haven't seen the literature support its benefit in the use. But if you're taking it for your bone health with calcium, that's fine. Again, if you have insufficiency or deficiency, I think it's incredibly important. For hair loss specifically, a lot of things are hormonal, that you have those hormonal changes. But again, you can talk to your doctor and see if your thyroid is okay. Again, check your vitamin D level. If it's low, then maybe that would be a cause as well. But you know, I can't give a straight answer as to whether vitamin D is specifically important for menopause, because there isn't the evidence to support that yet.
Great. Hey, Garima, so for a woman who cannot take hormone replacement therapy for any number of reasons and has some coronary risk factors, you know, what can they do around menopause that would, you know, maximize risk factor, you know, modification in terms of reducing their risk of developing coronary disease, vascular disease?
Yeah. You know, we don't prescribe, first of all, they can't take hormone replacement therapy in your question set. So we don't prescribe hormone replacement therapy, but irrespective, we don't prescribe hormone replacement therapy for cardiovascular heart health. Like that's not the goal of doing that. A lot of people say, oh, you know, if I take hormone replacement therapy, my lipids will go down. Yeah, they'll go down, but that's not why we're giving that to you, right? So that's number one. Number two is if for whatever reason you've got a history of really, you know, bad coronary disease, you've had a heart attack, you've had a stroke, or you have lots and lots of disease in your heart that make you very high risk, then HRT or hormone replacement therapy is probably not a good option for you. And I think in that case, you've got to try alternatives. Alternatives are depending on your symptoms. So if you have, you know, and they're all experts here, well, I'll let them answer. But if there is a sleep problem, then, you know, sleep supplements, magnesium, or, you know, being able to be prescribing an SSRI or something else that helps with their sleep is important. If their symptoms are vasomotor, then we've talked a little bit about Veoza and other alternatives that can help with the hot flashes. There's a lot of things you can do. You know, I think that from the perspective of cardiovascular health, there are benefits of daily exercise, which are beyond weight loss, right? Their daily exercise, daily cardiovascular exercise will do a lot of other things. It helps boost your metabolic rate. It's really good for, auto checking your blood pressure and automating your blood pressure and trying to help reduce that, catecholamine reduction overall, and better sleep also. So having that conversation with your menopause provider as to, I can't take a chart to you for X, Y, and Z. What else can I do for my heart health? And for my cardiovascular health, I think it is also important. So definitely sleep is a big driver there.
Great, thank you. Erin, and any relationship between hormone replacement therapy and reducing the risk of dementia?
So that is a tough question. Some studies show that patients who have severe vasomotor symptoms and are at higher risk for dementia, and if they treat them, that it can reduce risk. But it's not a blanket statement for everybody that using hormone replacement therapy is going to help or prevent dementia. So it is not a primary reason that we would prescribe that for somebody.
Anything that we didn't talk about, because we're almost out of time. We have about another minute here. I'll open this up to the panel. There were a lot of questions, and I apologize. We really couldn't get to all of them. I tried hitting most of the topics. Is there anything that you want folks out there to know that we didn't touch upon? Other than the fact that much of this is nuanced, all of it requires a conversation with your physician. Don't be afraid to advocate for yourself. And some people wanted to know, I think we're going to put a slide up with contact information, but we have a group here which is multi-specialty that specializes in these issues. And these are the things that you want to be talking to patients about, right? All right, well, I'm going to leave it there, but we're just about out of time. So I want to thank our panel tremendously, Dr. Dastmalchi, Davis-Wilensky, Dr. Sharma, and Dr. Perucci for joining us tonight and spending this time. I want to thank Rana, who's in the background, for helping coordinate this whole thing. Remember that a survey is going to pop up at the end. Please take a couple of minutes to answer it. If you want to be contacted, there should be a contact slide somewhere, but you're going to get a copy of all the slides. And make sure to submit your name and contact information if you want us to contact you.